chat. We are so excited that you're joining us, and I will turn the floor over to you. Yeah, thank you.
Thank you for that introduction. And many of you know my plan really was to be there in person. However, thanks to some airline snafus, I think the crew or something didn't show up. My flights kept getting delayed, finally canceled. But I'm really very pleased that I can talk with you today about some of the work we've done in Connecticut, and it involves the focus of our work has been primarily on primary care teams, and we've been kind of pivoting some of our work to the whole issues of workforce shortages in the primary care space. There are a couple slides here that are CE related. I'll put the code up at the end, so we're going to skip by these. If I was there in person, I would ask you to give an indication of what discipline you're in, because I know you have a very interdisciplinary program. So if you are joining us remotely, if you could just put it in the chat which discipline you are, that would help me to guide some comments throughout the discussion. So go ahead and put that in the chat, and I will wait and see if Sydney can give me a thumbs up as to what most of the responses are.
Yeah, the majority are pharmacists joining us. There's some students, state government. The majority are pharmacists. We have one fellow joining us. Yeah.
Okay, great. And then if you are in a primary care workplace, if you could put in the chat what type of workplace you're in. If you're not, you can always put other, or there's academia and other things, but just to get an idea of how many folks are either in a workplace now, or perhaps you've worked in a primary care setting at one point in your career.
So far, the majority are academia. We have one outpatient clinic. We have a retail pharmacist. One for B, federally qualified health center. Yeah, that's all that's come through.
Good. So it sounds like a range, which is good. Most of my comments today and the work we're describing will actually focus on the settings of federally qualified health centers and physician office, but I think they're very transferable. The work we've done will be transferable to other ambulatory care settings as well. So with that, we're going to get started. And I have had this question asked of me so many times in my career. I wish I had $1 for every time it's been asked. So I'm interested in hearing some comments from you. I don't know if the best way is to have that put in chat. I'll leave that up to Sydney, but the question is, well, gee, we'd love to get started and would love to expand, but how do we assess the impact of pharmacist services on a primary care team? How do we know it's going to be successful? So I want to get some feedback as to what kinds of assessments you've been aware of, you've used yourself in your own practices to show someone that we can be very successful in the impact of our services.
Yeah, feel free to put them in the chat or just speak up if you feel like unmuting yourself. And then in the classroom, there's microphones around that people can participate. But someone said looking at patient outcome improvements in the chat.
That's common, yeah.
Patient satisfaction. Improvements in quality metrics, provider or patient satisfaction surveys, RX capture, increased RVUs.
You're getting the big categories. So I'm going to put up on the right of this slide, what we see usually is 3 buckets, I call them. One is clinical, so that would include more the patient clinical outcomes that someone mentioned. Things like, are we reaching therapeutic goals? Are we preventing or managing adverse drug events, interactions, medication adherence measures? The one I didn't see or hear was financial, which is a tough one to really get your hands around. But everything from cost savings, meaning actual expenses, especially now with value-based contracts, looking at total cost of care, sometimes just looking at medication cost savings. There are a number of people who still are interested in cost avoidance, or that may be the only data that they have available to them or can project. I would say, at least in my work and experience, it's not as powerful as actual cost savings, but it may be the best you can do. And then I'm sure all of us have had at one point or another that famous ROI question. Well, what's the ROI that you can guarantee me? And I'm glad to hear that several of you talked about patient experience, and CAP scores are one way to do that. There may be other surveys that you're using in your practice site as well. But those are the three large buckets that I think of. And I think we commonly think of when we're trying to talk about what are the measures by which we're going to assess our impact. And on the left side of this, you've all seen the Triple Aim diagram of better care, better, healthier people, population health, and then looking at smarter spending. So those are the three buckets that we think of. And over the projects that we've done, during that time frame, the move was to the Quadruple Aim, which you see on the right. And I've put the reference there if you're not as familiar with it. Tom Bodenheimer and Christine Sinsky published this almost 10 years ago, and it added the dimension of improved provider work life. Some of you may know in this space, there's also now a quintuple aim of 5 components, and the newest component being added is social determinants of health, which is, I think, something where certainly pharmacists have a great deal of experience and can make a positive impact. But at the time we were doing our work, we were just up to the Quadruple Aim. And we looked at that quadrant about improving provider work life. And many of you who have worked in ambulatory care settings, community pharmacy settings, anecdotally, even if we don't have a lot of research to reproduce it, anecdotally that you've had so many instances where providers have talked to you or mentioned how you really add to their provider work life. And you can add to it in positive ways or negative ways. And that's part of what drove us to the work that I'm going to discuss today. So the work we're going to talk about is at a high level, and I'm referring you to the article for a real deep dive, was published about 1.5 years ago in RSAP. And Mary Mulrooney at the time was a fellow working with me at the University of Connecticut. And she was a student of ours who I worked with closely, who did her Pharm.D, and she also did a dual degree with a master's in business administration. And I've wanted to do this for so many years, and I finally found that, it was something that would be perfect for Mary with her background of having an MBA to do some modeling and create a forecasting tool that could really look at the primary care services we were providing and how it aligned with that 4th Quadruple Aim. What impact did we have on provider clinician workload? And one of the reasons I wanted to do that was that we could do the other 3 buckets pretty well, but there's sometimes a lot of question or pushback. If people don't like the results that you find, they will attack your methods. And I thought, we have so many good pieces of work on clinical outcome impact and some financial impact, and more growing was the impact of patient experience or more satisfaction scores. But we really didn't find much of people addressing that 4th dimension. So that's kind of what spurred us to write the article and do the work. It also happened to dovetail really nicely with a project we're involved with. We've been very involved with the Connecticut State Office of Health Strategy here. We worked with them very closely to get a CMMI, CMS Innovation Center, that is State Innovation Model Grant, for about $45 million. And part of that funding was a competitive process to develop a technical assistance. So TA is technical assistance program, whereby you really help on the ground, on site many times, organizations to move forward. And this program was specifically offered to advance the primary care involvement of clinical pharmacists. And there were 9 primary care organizations that were eligible for this, being that they were part of the state innovation model. And it offered them at no cost a very tailored and strategic approach to either initiate or advance clinical pharmacist services. So that was the framework for our work. And out of that work, one of the projects was to develop this tool that we're going to talk about today. The paper was written with 2 objectives. One, to describe the development of the tool, and I'm not going to spend as much time on that. There are detailed equations and variables and all the math behind it. For those of you who want to look at it and maybe adapt it, feel free to do that. That was the intent of publishing it. But secondly, the one I'm going to talk more about is to discuss how we use that PCImpact and some of the nuances behind it that can help for key decision-making about either initiating or optimizing or expanding integrated pharmacist services in a primary care. So to set the stage, I mentioned that it was part of a larger statewide initiative. Out of those 9 eligible primary care organizations, 4 very large primary care organizations wanted to be involved in this pharmacist technical assistance program. And you'll see the range there. We had, I thought, a nice range of F2HC, academic institutions, a for-profit ACO was involved. And the 2 that I've highlighted in purple at the top are the 2 organizations that identified this need for getting some idea of forecasting tools that could help them. Each of these organizations, as part of their commitment to work in this program, they had to have a full-time pharmacist. So all of them had pharmacists, but the FTE workload really ranged from a part-time 40% effort to a full-time person working dedicated 100% for patient care services. The types of people that we worked with included very executive level, C-suite type individuals, people who were clinical administrators, chief medical officers, other members of clinical teams, and pharmacy leaders. And the overall project was to help them optimize their integration of clinical pharmacist services. As I mentioned, all of them had pharmacists. Some of them, the spectrum really ranged. Some of them had pharmacists, but had very little direction on how to fully optimize the use of the pharmacist, how to select high value patients to receive those pharmacists, especially when you had, limited resources, had 1 pharmacist and maybe not even a full-time effort. The 2 that we worked with, the statewide federally qualified health center and the academic affiliated physician organization, which are fairly large, you can see there, had 200, 300 primary care providers. They were interested in evaluating this impact and the value in the primary care setting. And then in some cases, we were able to help them utilize either internal data or third-party data needed to assess the impact. So you can see the scope of this was pretty large and it was very tailored. But what we learned early on in the project is little was known by these primary care organizations about the different types of models that pharmacists can practice in. So the 2 that we will focus on are direct care and population health pharmacists. And so, and then not only the model, but how each of the models has an impact on either pharmacist workload or provider workload. So that's the background for how we started this project. I mentioned we worked with 2 large statewide organizations, and the teams, besides our own team at UConn School of Pharmacy, we had the input of the clinical pharmacist involved in those sites. Sometimes we had pharmacy leaders. So in one case, we had an associate ambulatory care pharmacy director. We had 2 medical directors, a chief medical officer or a regional medical director. And we also had the involvement of a senior quality improvement manager for population health in one organization. And the article goes into great detail about these 4 steps. I'm going to collapse it for the sake of time, but I've referred you to tables or figures in the article where you can get more in-depth information. So there were 4 steps. One is to identify the primary care organization practice model. And I'll describe that in detail. The second was to define your data input variables. And there's a whole table 1 in the article that goes into much more detail than we have time to discuss today, but it talks about what are those input variables. Things like time for targeted medication reviews or comprehensive medication reviews, time for a patient visit, time for a PCP to review and implement pharmacist recommendations, and there's more. So that gives you a list of what are some of the variables to think about to have data input. And then the third step was to what we did in this project. We had the luxury in this project of actually doing a lot of on-site work. So we did on-site workflow observations. There's a figure in the article of the actual mapping of the workflows that we used in the tool development. And sometimes that was, if you didn't have an on-site specific workflow, time, almost like a time and motion study, then you also might have some recommendations there about default data that you could use. And the last step, which is what we're going to focus on in the rest of the talk, is to look at what were the data output variables. So all the calculations, the detailed math equations are in this article, and you can look at those. But the 3 data output values that we were focused on were pharmacist workload capacity, the impact on PCP time, and the impact on number of patients that would be impacted. So it could be a visit or a number of patients involved in medication reviews. The first thing that we found ourselves doing is really working closely with those organizations to help them define what type of practice model they wanted to either continue or to explore looking at different practice models. I might say just kind of editorially, in this project, we found that even though there were pharmacists, sometimes had been involved for, not brand new pharmacists, had been there for years, they really, the organization leaders weren't necessarily aware of the various types of practice models we can deliver. And they had kind of defined the one that they thought that would work best for them. But we found early on we needed to kind of expand their view. And once we expanded their view, we could give them some comparisons for, even if they had a pharmacist working there for 3+ years, they realized that no one had ever kind of showed them, or they weren't aware of what the other models were and how to compare those. So the definitions that we used, and I have to say it was used, these definitions are not necessarily universal, so you have to be careful about making sure you know what our definitions were. But we used 2 models, population health and direct patient care. And under population health, there were 2 types. One was a very targeted medication review. So these were situations where the pharmacist reviewed and assessed medications specifically for a disease state. So that was the medications related just to that disease state. It was usually hypertension or diabetes. And then the pharmacist, in the cases for our project, the pharmacist, and this was at the recommendation of the site, not something we recommended, the pharmacist did not have any kind of even telephonic communication with the patient. So the patient was not something that, you could factor into this. It was really strictly the pharmacist doing a med review of what was in the chart. Sometimes they would call it pharmacies, a community pharmacy, but there was no patient contact. And the pharmacist would send their optimization recommendations to the PCP for implementation. And in most cases, the population health model was not a referral model. It came from databases of quality measures, patients that were not meeting their quality measures for outpatient control of hypertension and diabetes were the two most common. The comprehensive med review was very similar, except that in this case, the pharmacist did not look at just medications for the targeted disease state, but looked at the medication optimization opportunities across their entire medication regimen. So that was the difference there. If we look over on the right side for direct patient care, there were two models. We had embedded pharmacists. So these are pharmacists who are embedded in the office, in the pharmacy practice, the physician practice. Some had use of collaborative practice agreements and others did not. So they usually were involved with pharmacist involvement, mostly on referral from the primary care clinicians in the practice. They would work with the patient for more than one visit, and you'll see how we model that in the tool coming up here shortly. But they really met with the patient as many times as needed until their therapy goals were met. They provided comprehensive medication management, and in the collaborative practice model, the pharmacist implemented the changes that were needed for any kind of medication intensification, or change in dose, or discontinue a medication. They could order lab tests. So within our state scope of practice laws for pharmacists, they have the ability very widely to make all those changes, and it's not limited to any one disease state or any one drug class. And then in the second model, if you had an embedded pharmacist who was not using collaborative practice agreements, the main difference is they then had to send their recommendations for med optimization to the PCP for implementation. So let's look at kind of the outputs here on the various types of PCImpact. So the first output category, as you recall, was pharmacist workload capacity. And this was very useful because many times the administrators or even some of the clinical leaders had very high expectations of what the pharmacist's workload could be in terms of the number of patients they could see or the number of reviews that could be completed. So this was the first modeling that we did. And you can see on the right-hand side, like right here on the green for population health, and then for direct patient care, we just put a reminder there of what the differences would be for the targeted medication review or the comprehensive medication review for Pop Health. And this was just a one-time medication review with recommendations going to the provider. And on the right-hand side, the direct patient care model, it was an initial visit for the pharmacist and the patient, and usually about an average of 4 follow-up visits over the period of the 12-month timeframe. So that's kind of the background. So what do we see? The population health model, the targeted reviews allowed for a higher number of patients served because it takes less time than it would be to do a comprehensive med review. So you can see the relative difference there. Under the direct patient care model, you can see that there's far less number of patients that can be seen and CMM reviews completed than the Pop Health model. And that mathematically makes sense to us, maybe even intuitively, we would be able to derive that. But to show that to clinical administrators and leaders about the difference in the models and how they impacted the ability to look at the pharmacist's workload was pretty eye-opening. Many of them were just kind of making up numbers. Well, we think our pharmacists, we have 5,000 patients in our population who are either have uncontrolled diabetes or uncontrolled hypertension, and we'll just put the pharmacist working on a pop health model to work with 5,000 patients. And they would think that that could get done in a very short, like months worth of time. And it really can't if we're doing it kind of with fidelity to our practice models. So that was the first output that we developed. The second one was to look at what impact did the pharmacist services in each of these models have on PCP hours required or saved. So in the population health model, you can see that there requires significant amount of time for the pharmacist or for the PCP to receive the note from the pharmacist, read it, review any assessment that they had to do, like if they had to go back and check some other lab value or a prior note or a discharge summary or something like that, and then to decide whether they were going to implement the pharmacist's recommendations or not. And that's the numbers that are in red, meaning that in this model, there are PCP hours that are required. And this was something that the chief medical officers weren't really thinking about, but it became quite useful for us to help them discern which model was best. And in that population health model, which they tended to gravitate to first because their instinct was, well, we want the pharmacist to work with thousands and impact thousands of patients, which is great for population health. It's, certainly you can get larger numbers of patients seen or reviewed, but they weren't thinking about the workload impact. And so in addition to this, we also had some qualitative reviews that we did where the PCPs commented in this pop health model that they really loved having the pharmacists review and make recommendations for these patients. But one PCP said rather loudly one day, we like the pharmacist, but the pharmacist is creating more work for us in this population health model, which was it wasn't eye-opening to us, but to the chief medical officer, it really reframed, I think, their thinking. In the direct patient care model, again, this is a model with 1 initial and 4 follow-up visits. You can see that the collaborative practice agreement model, in that model, the CPA, use of the CPA saves about 6 times the amount of hours it would be needed when you use the CPA model. So you would save 640 hours of physician time if they were managing as closely as the pharmacist was. And that really was an eye-opener because it does reduce PCP workload burden. And when you get to that quadruple aim and whether it's you call it the joy of practice or provider workload, whatever, that was the key that opened up a lot of opportunity to move to a model with embedded pharmacists using a collaborative practice agreement. It's very intuitive for us, but we couldn't break through that until we really started using these kinds of numbers to show them the difference. We also translated that because I don't know about other parts of the country, but I'm assuming you have similar challenges as we have here in the Northeast. For a new patient to get an appointment with a primary care provider could take up to 6 months, and that would be short. So we looked at the impact and started talking about the impact on patient visits that could be opened up. And here you can see the greatest opportunity is with the pharmacist using a collaborative practice model because the pharmacist is really not requiring any of the physician's time to read, assess, and implement changes. So we did a calculation. Again, this is very specific and it's described what our assumptions are in the article. But roughly for this one opportunity we had with a larger statewide organization was it opened up about 1,900 patient visits per year. And that directly resonated with CEOs of health systems, medical directors, because they know the stress they have of looking at patient access. And to bring that down a little bit more concretely to a weekly basis, it's roughly 40 primary care appointments per week that could be used for more acute and immediate access patient visits. What's happening here is if you call a very busy practice, primary care practice, and they don't have the ability to see patients, they're basically referring them to either urgent care centers or emergency rooms. And we know that's really not the best way to be efficient from a cost standpoint. And the last workload output that we, or output variable, I should say, that we looked at was what impact this was going to have on either medication reviews, meaning how many reviews would you be able to handle in terms of being implemented, or patient visits impacted. And this was revealing to the practices as well, because they didn't realize that for every, in the population health model, for every medication review that a pharmacist did, the percentage of recommendations that were implemented was 40%. And I'm sure there are people on this call who may have done similar work, and it might go up to 60%, but it's certainly not 100%. And it's due to a lot of factors, right? It could be due to patients lost to follow-up. It could be due to the fact that the recommendations sometimes are timed such that the pharmacist recommendations are provided, but the patient's next visit isn't for 3-4 months, something like that. Or it could be that in some cases, the clinician who knows the patient well knows some factors about that patient and their history that are unknown to the pharmacist, and they decide that although the recommendations might be clinically sound, it's not going to work from an implementation standpoint with that patient. Whereas we see very different results in terms of implementation percentage over on the right-hand side, somewhere between 90 and 95% of the pharmacist recommendations there will be implemented. And I think the 90%, our reason for putting 90% was primarily because these are referred to, from the primary care clinician to the pharmacist. So it's not a detached kind of referral from a dashboard or a population health list or quality metrics list or something like that. So there is a higher percentage. And we could have put, I guess, 100% in terms of embedded pharmacists with CPA, but there are times when not everything is going to be implemented. So it could be the patient deciding that they're not going to implement the patient behaviors that are needed, let's say. So we were careful to just make that 95%. So those are the three large output variables that this tool will help to elucidate a little bit for those in the practices that have to make decisions about use of a resource or the impact it might have on provider workload and that sort of thing. So I want to close with a couple of scenarios that we found as to, now that you have an idea what the tool does in terms of calculations, how can it be used in practice? So the first example was one of our organizations had a part-time pharmacist. They actually had, they had a full-time pharmacist, but they had the pharmacist only working on medication optimization services for about 40% of that workload. They were, pharmacists was scattered across a number of different initiatives in that organization. And this is an example of where the chief medical officer, the VP for clinical services were so excited to have this pharmacist working there, but they couldn't understand why that person wasn't more productive. And so we had to, use this tool, and it was very eye-opening to say that, yes, you might have 5,000 patients who aren't controlled for blood pressure and A1C, but your pharmacist is only going to be able to do, in this case, they wanted targeted medication reviews. They did not want to use comprehensive. And they saw that, what we were able to show them is that you can't expect 5,000 patients in your database to be reviewed by this 0.4 FTE pharmacist. And we were trying, there was a time when one of the chief medical officers was more familiar with an embedded pharmacist model with a CPA. So we included that in this discussion for them to show the differences. The second, so that's the population health model. The thing we've tried to point out is you get less numbers in terms of pharmacist workload capacity and in the number of unique patients, but you really have to balance that if you're going to think about, one model of pop health versus, direct patient care. You have to be prepared for what the impact is on the PCP. And this was the biggest aha moment, I think, for these clinical leaders, was they really didn't take into account at all what the population health model required in the part of physician time that was needed. And most of this time, as some of you in ambulatory care or outpatient physician practices know, most of this work, this review of the pharmacist recommendations, is not done during the day. It's done, between 8 and 11 o'clock at night when they're reviewing labs or refills, or, oh, I've got that pharmacist note now. And we weren't getting a lot of positive feedback. They loved the fact that it was there, but it was just adding to their workload. And that's, I think, was the eye opener that this tool allowed the clinicians to see. They still decided, we were trying to convince them, obviously, to go in the right direction on the right to direct patient care, but they went with pop health and had to live with the fact that they were getting some negative feedback from clinicians. But what it was used for initially was really just to set a realistic benchmark for what the pharmacist's workload involved. The second scenario that I'll mention is, this is a case where there was a full-time pharmacist and they were trying to evaluate, this was a new hire for them. They had not had a pharmacist involved in their practice, and they were trying to decide in a very open-minded way, should we start with a population health viewpoint and practice model, or should we look at an embedded pharmacist model? And they wanted to go, if they did pop health, they wanted to do a comprehensive med review. So all the medications in that patient's active med list, versus looking at direct patient care. They had not used a pharmacist in an embedded model. They had not developed collaborative practice agreements. So they wanted to sort of see what the use of a CPA and versus no CPA would do. So you can see that certainly the direct patient care model was less unique patients. So you had to be much more specific on selecting the highest risk patients and identifying what those criteria were going to be. It did save PCP hours. So they really were very excited about, given their primary care burnout and staffing challenges. And this was pre-COVID, by the way, what impact that would have there. It did open up PCP visits. So they really liked looking at the impact on improving patient access. And they weren't that aware, or really weren't cognizant of the fact that, the direct patient care model does allow a higher percentage of implementation of pharmacist recommendations. So it was helpful in that case to show what the differences were. So I'm going to just summarize here by giving you kind of what were our takeaways from this work and its application in our technical assistance program. First is that both primary care and pharmacy leaders can use a tool like this to plan for new or expanded pharmacist integration, so it can work in both situations. It can help the practices look at the various practice models that they probably are not that aware of and determine which model, whether direct patient care or pop health, would be a best fit for that organization's needs, as well as what their workload is for primary care clinicians. It can determine their pharmacist workload capacity and estimate the impact of that pharmacist integration on PCP clinical workload as well. As you saw in the application of it, using the direct patient care service model, practice model for pharmacists with a collaborative practice agreement can reduce the clinical work burden that's needed for the primary care clinicians. And it also can open up improved patient access. And even, this work was done, almost 4 years ago, but we still it resonates very highly with clinician administrators, health policymakers at the state level who are dealing with tremendous amount of clinician shortages, as well as kind of a real kind of snag with how do we improve patient access. So sometimes having, what I found too is all of us have had anecdotes in our own clinical practices that we know well, but sometimes having a neutral tool, a forecasting tool, this is simple. This is a spreadsheet. There's no app. There's no phone app. We've been asked if we're going to develop a phone app. No, we're not doing that. But we tried to provide in this article the detail that's needed for any type of pharmacist model and you may want to adapt it and have data, for how much time your pharmacists are spending on a certain aspect of doing med reviews and how comprehensive they are. And you may have data, workload data on your direct patient care models for embedded pharmacists as well. So we would encourage you, for those of you who want a deeper dive, to go in and read it's a little dense, I will admit, especially some of the equations, and it looks like a math paper in some respects. But hopefully it'll give you some understanding of the assumptions and the formulas that we've used to come up with a tool, and also allows you the greatest flexibility to adapt it to your work setting. So with that, I will just ask if there are any questions, comments. Would love to hear from those of you who have practiced in pop health models or embedded clinical pharmacist models. Would love to hear whether any of this resonates with you, or if you've done any work at your own site that that might be helpful to share with others.
We have a comment in the chat. Starlin Hayden Gretting says, your work is fantastic. Thank you so much. If you all have questions, you can put them in the chat and I can say them on the Zoom.
Thank you, Starlin. I saw that you had you were on the list of attendees. So I know you've done a lot of work in this space as well, and would love to hear any other comments. If there's a way to open mics, it would be great to hear from people as well.
Marie, I have two questions while people still think about their questions and write them on the chat. I have two questions. So one is the targeted medication reviews and the comprehensive medication reviews are billable services, at least to Medicare. Whereas the chronic disease management, working under a CPA are not directly. I was wondering, would like to hear your thoughts and what you heard from the clinical leadership at those practice sites as to whether they were able to attribute a number to how much revenue they've gotten from open visit slots that they previously didn't have, or meeting some quality measures that they previously weren't meeting. I'd love to hear, your experience with that. And then, yeah, okay. And then I have another question, but.
Okay, let me answer that one because that one could take another hour, Teresa. So I'll just tell you kind of the experience we had from this project. And the site that was doing what I would call the highest level of integration of pharmacists with the CPA in a direct patient care model, embedded model, they were actually billing for this and getting some revenue using E&M codes. So they were doing 99211s, 212s. So there was revenue coming in from that. They didn't, of course, you can imagine that I asked, but practices are very, especially when you are an outsider, as we were, are very reluctant to tell you about how much they're actually revenue they're receiving. So I know they were billing. I don't know the amount that they were receiving. It was some, but I'm not sure it was enough to pay for the full-time pharmacist salary. That practice also had several, had probably 5 or more value-based contracts with payers. They were an ACO. And so in many cases, they were referring a lot of patients who were uncontrolled diabetes patients. Based on the measures, they were missing their measures, or they had opportunity to improve their level of performance incentives. And so I don't have hard data to tell you what that is, but I can tell you that the reason why that pharmacist had a disproportionate number, probably over 50% of the referrals were for uncontrolled diabetes, was because it was helping them meet their measures under some of these value-based contracts. So it could have been ACO models, or it could have been with commercial payers. It probably was performance, pay for performance incentives. So that's the best I know about that. And you had another question, I think, Teresa.
Yeah, so the other one was sort of some details of the data collection on the field. Things like the number of visits opened, the time spent. Did you collect exactly like how many positions open, or was that based on sort of an estimate on?
Right. Yeah, it was. So what we did is we actually did on-site workflow mapping and actually did time and motion studies. In addition, so we really just observed and watched what happened for 4-hour blocks at the practices on various days. And then the other thing we did was we interviewed physician leaders and frontline clinicians, meaning frontline primary care providers, to build some of it was based on assumptions. We made assumptions, like for instance, an assumption of for every one complex patient that you refer to a pharmacist for, let's say, an hour initial visit, by the time, we've got multiple diseases, multiple meds, how many patients does a primary care clinician see in a 1-hour time? Well, depending on how they book their appointments, in this case, it was roughly between 15 and 20 minutes. So there were assumptions that we made that we did on observations. We built some assumptions in on observations of workflow, and then we tried to true it up with what they were telling us was their either internal policies for amount of time spent with a patient, or their scheduling blocks or things like that. So we tried in the article to be careful about when we had data coming from observations and when we had data that was some assumptions that we had to include in the model.
Thank you.
I think we've got a couple more minutes. So if there's any other questions, I don't know if there's anything in the chat that.
Starlin just asked again, in our population space, DM and CVD, we are working more with a larger review of the overall state population because the public health department and CDC desires the biggest bang for their buck. With those DM metrics and goals, as well as CVD metrics. And yes, the PCPs cannot see all the type 2 DMs long enough to optimize their care.
Yeah, that's, thank you for sharing that, Starlin. And I think we have seen the same thing, is that there are, literally thousands of patients that we could impact who, for a variety of reasons, whether it's, and depending on the population, some of it's a matter of just social determinants of health, that they may not be able to come in as frequently. The one thing that I will say is in some ways, I'd love to do this again and factor in telehealth, because telehealth was not an option when we were doing this work. But I think in most cases today, one of the positive aspects of the pandemic was the use of telehealth. And so there is another model in my mind, a third model, which would be population health that has a telehealth component or even a direct care. I know that the pharmacist who was embedded that, we worked with during COVID, that pharmacist converted many visits to telehealth visits, especially if they weren't new patients. They were patients that she had worked with and knew and had established some trusted working relationship. She converted those to telehealth. So I think today there really is another model, and I would challenge others to kind of, think about whether or not there's work there that you've done a lot of telehealth and see if there's opportunities there to build on this model and make it even more contemporary with what we're seeing today.
Another comment says, and remote home monitoring.
Yes, absolutely. Yep. I didn't even think about that because that wasn't part of our project, but yes, telehealth in a combination with remote monitoring might be another avenue to take. Well, I know that we're kind of getting to the top of the hour here. Are there any more comments or questions that you can see, Sydney?
We have one in the classroom.
Oh, okay, go ahead. Sure. If somebody's talking, I can't hear. So maybe if someone could rephrase it, that would be helpful.
Let me switch out this remote really quick.
Can you, Dr. Smith, can you hear me?
I can, yes.
Okay, great. Hi, Cindy Kirkwood here at PCU.
Yes, hi, Cindy.
Hi, I was just curious, based on your results, if you shared them with the organizations you were working with, did they implement any changes in their pharmacist model?
Great question. So in the first one, we really were trying to convince them not to go in the direction of a pop health model because of the feedback that they were getting from physicians in the amount of time it was taking. But that is what they ended up doing. They traded off. They said that for them, the trade-off was to take a little bit of heat from the clinicians and pursue the pop health model. In the other model, the other group was already doing direct patient care for the most part with collaborative practices. And what they were interested in doing eventually was to use that model. The full-time pharmacist was actually being shared across 3 practice sites. So it was 1 FTE, but 3 practice sites out of 50. And what they used the model for was to really do some planning on the number of pharmacists to scale that. They wanted to do it, across, they had 50 and they were going to ramp up, to like 10 or something like that. So it was a planning tool for them internally in the second model where they already had I thought a very well-established program. It was just they were trying to scale it to a larger group of practice sites.
Great, thank you very much.
Yep, thank you. Great question.
If we're done with questions, I've posted all the CE information in the chat.
Good.
In the classroom, I can give you guys the codes if you guys need it. Yeah, if there's no more questions, just want to thank you again so much for joining us. Again, we're sad you're not here in person, but we're happy that you're still able to do this virtually. And like you said, these kind of things are the good outcome of the pandemic, and we can do these things easier. And so, yeah, we appreciate you joining us.
Great. Thanks for having me. And if there are questions that come up later or people want to talk offline about how they might utilize the tool, I'd be happy to take